working? Okay, we have a limitation on time, and I'll go quickly with this concept. But basically, there are many women who have had their cancer treatment or other chemotherapy that never had fertility preservation. And there are women that simply have ovarian failure with undetectable AMH, and they've never had fertility preservation. But there often are eggs still in those ovaries, and that's what I'm going to talk about briefly. Fertility preservation in patients who never had fertility preservation with undetectable AMH. And this goes into the issue of what controls ovarian longevity. And I collaborated on this with Katsuhiko Hayashi. And it all came from our discovery with transplant patients, ovary transplants, that the FSH comes down after about 4 or 5 months, and the AMH at the same time goes up to extremely high levels and then goes down to very low levels. And yet the ovary continues to function, or the tissue, little piece of tissue continues to function for the next 10 to 12 years. And that just means that there's a massive over-recruitment of primordial follicles at the time of the transplant that you see 4.5 months later after the recruited follicles, the over-recruited follicles, finally become sensitive to gonadotropin. But then there's a depletion of follicles for that reason. And nonetheless, the ovary tissue pieces last a very long time because as the ovarian reserve goes down, the rate of primordial follicle recruitment goes down. This isn't working. Maybe this will work. I won't use this button. Okay, so massive primordial follicle recruitment, we decided, occurs because of the low tissue pressure at the time of the transplant. And what controls recruitment of follicles in adults from the resting phase is a gradual release from the fibrous cortex, just like in the fetus. So the fetus otherwise would wind up being born 9 months later with no eggs whatsoever if there wasn't a control of meiosis. Because at 6 weeks in that early fetus, in the early embryo, the exposure to retinoic acid causes the primary ovary, the oogonia, to go into meiosis. And if it's not arrested in that early meiosis, all those eggs will be gone before the embryo is ever born. And if you look at your pieces of ovarian tissue and you do an ovary transplant, you'll see the most dense stroma is external. And as you go internal, it's less dense stroma. It's obvious under the operating microscope, but you can't miss it. And finally, the least dense stroma is when you go most internally. And we know that follicles develop from the outside to the inside, and then once they form a Graafian follicle that's very big in the medulla, they explode through the surface and you ovulate. But development of the follicle is not from inside to outside, it's from outside to inside, following the ovary tissue pressure gradient. And in fact, the reason that these early oogonia are not gone is because they migrate in the early fetus to the cortex, which is very, very stiff connective tissue. And oogonia that did not migrate to that cortex, that are in the medulla, all die off. And we know the AMH declines gradually. This is 24,000 cases that Teramoto accumulated over a lifetime from 28 years to 46 years of age. And we know there's a gradual decrease in AMH with age. However, during pregnancy, when the intra-abdominal pressure is increased, the AMH actually does not go down. And after delivery, 3 months after delivery, the AMH goes up again. So intra-abdominal pressure puts the ovary at rest and prevents follicle recruitment. And you can see from other studies that the anti-Müllerian hormone concentrations postpartum go up, and usually 3 to 4 or 5 months after delivery. But also, I didn't show this slide in the last talk, and I probably should have. But it's been known for a long time, for the last 15 years, that as the ovarian reserve goes down, the rate of primordial follicle recruitment goes down. Now, this could be from endocrine factors or exocrine factors in the ovary, but it could also be simply due to the fact that as the ovarian reserve goes down, the density of the fibrous tissue of the ovarian cortex goes down. Increases because there is a less distribution of eggs, and so there's automatically an increased pressure in the cortex. And we can see that when we dissect ovary tissue from young women and from old women, that the cortex in the old women is much denser and thicker and much tougher than in young women. Now, also, Hayashi was the one I first presented this concept to, and he proved it finally in vitro by taking in vitro produced oocytes and incubating them either in a normal incubator or at high tissue pressure in a high tissue incubator. And what he found is that meiosis in these artificially produced eggs was halted, was stopped by high pressure incubation. And when the petri dishes were taken out of the high pressure incubator and incubated at normal pressure, the oocytes resumed meiosis. So, and this is a diagram of that was published, just showing that the extracellular matrix density is what controls primordial follicle recruitment or arrest. So mechanical stress, actually accompanied by nuclear rotation, is involved in this dormant state. And this is a very interesting set of slides just showing that the dormant follicles are on the outside where there's dense ovarian tissue, and the recruited oocytes are on the inside where there's less dense tissue. And you'll see where there's less dense tissue, the nuclei rotate. There's no rotation, in the more dense tissue, the nuclei rotate, and the rotation of the nuclei prevents meiosis from continuing. But the oocytes that are more internal, that are actually developing and leaving the dormant state, they have no nuclear rotation. So nuclear rotation in the external dense cortex and no nuclear rotation inside. So what happens is there are usually a few eggs trapped in the cortex of menopausal women with ovarian failure. Now, Kawamura thought that he could solve this problem by fragmentation of the ovary tissue and by incubating in a way that he blocks P10 and the Hippo pathway. But in truth, it's all mechanical. And you can look in any woman's menopausal ovary who's been menopausal for less than 3 years, and you will always find some eggs. There will always be a few eggs trapped because as the ovarian reserve goes down, the rate of primordial follicle recruitment goes down, and the oocytes are arrested, and she stops losing eggs. There may even be several eggs in this tissue from menopausal women. So tissue pressure is what accounts for ovarian longevity, and I'll go through a few interesting cases because time is limited and we have to have time for questions as well. And I only have a few more minutes. So this is the first case that intrigued us. She was a young girl at 5 years of age, had acute myelomonocytic leukemia, treated with a bone marrow transplant. And of course, in those days, they weren't freezing the ovary tissue, and she had no fertility preservation. And so as a teenager and a young adulthood, she had no periods and undetectable AMH. And if you want to look through the details of what she received with alkylating doses of cyclophosphamide that were just huge and all of the other chemotherapeutic agents, you can see why there would be no chance for her to have any remaining oocytes once she was cured of her leukemia. There she is now at 20 years of age. I'm in there, and my clinical partner, Dr. DeRosa, is there with her. And we decided to see whether or not there were any eggs, despite undetectable AMH. We used our minimal stimulation protocol because we have found when there is a very low ovarian reserve in women over 40, the response is better with a minimal stimulation of FSH. And I can explain that in a little bit quickly. But wait, okay, this is just a summary, but I'll go through the details. We now have, after 2 years, 8 beautiful M2 oocytes from this young lady who had never undergone ovarian preservation or oocyte freezing, obviously, when she was 5 years of age. And she was told she had no more eggs left. She was clearly menopausal, and now we have 8 M2 oocytes. So this is simply the protocol that we normally use for minimal stimulation. It's a combination of Clomid and FSH 150 IU every other day, not every day. And the concept of this is that we don't feel that by elevating the FSH, we're really getting more eggs or better eggs. That's very, very clear from all of our previous evidence, which has been published. However, what you need the FSH for when we're stimulating patients is that as follicles develop and secrete more estrogen, that inhibits the FSH, and the FSH goes down as the estradiol goes up. So we don't want the FSH to go down. We want it to stay at that even, somewhat higher level so that we can get more follicles. And this is just a view of her. I've got a lot of flow sheets showing her stimulation, which is very minimal. And you can see she developed after 11 days a 1.7 centimeter follicle, which really kind of shocked us. And there was the follicle. And we retrieved the follicle, and we were in the operating room. Everybody cheered and screamed when we actually got an egg from this young woman that had no eggs. And there she is afterwards telling her we actually found an egg. But we did it again, and we found more eggs. And again, and many times we found no eggs. There was a follicle that was empty, or there was no follicle that developed. And we kept on trying this because she was determined. And eventually, we found more follicles. And we were able to get more eggs that were metaphase 2 normal eggs, just with 150 IU of FSH every other day and 50 milligrams of Clomid every day. The reason for the Clomid was as an anti-estrogen to prevent premature ovulation. We really don't need antagonists as long as we keep them on the Clomid, not just stopping it after 5 days for stimulation, but the major purpose of the Clomid is to prevent premature ovulation. And there are just more flow sheets and more metaphase 2 oocytes. And I'm just showing all of these just so that you'll really see that this is for real. We're not kidding about this. More metaphase 2 oocytes. And the Clomid just prevents premature ovulation, but the FSH, very low dose every other day, is perfectly adequate to get these eggs. And we retrieve the same number of eggs in women with low ovarian reserve or high ovarian reserve using low dose FSH as with very high dose FSH. We don't find that increasing of the FSH increases your number of eggs in the majority of patients. So we have 8 frozen M2 oocytes from her, despite undetectable AMH and after bone marrow transplant for leukemia. And case number 2 is a Turner syndrome case with less than 0.015 AMH. And again, we were kind of shocked with stimulation to get good quality M2 oocytes. And we actually have 5 on her now, frozen. And she is she's actually Orthodox Jewish Haredi, which means they really can't get a good partner for marriage unless they're capable of having children. And so it was very important. Her whole life depended on us being able to get good quality eggs. And we're continuing to do that with her, and she's now engaged to be married. So we have 5 frozen eggs from her, and case number 3 is another example where we just started doing this. We weren't really interested in it before, but now we're amazed by it. And again, a beautiful mature oocyte in a 41-year-old woman with undetectable AMH. And she developed a normal day 3 embryo, and we're just going to keep collecting oocytes on her, even though the AMH says that there are no oocytes left. This is a 47-year-old. Again, with a good M2 oocyte. Again, another M2 oocyte. So we're able to get oocytes with the most minimal stimulation from women who we thought were completely menopausal. And in general, our success rate over the course of many years with low ovarian reserve baby rate is 31%. So it's definitely worth it. So in conclusion, ovarian longevity is controlled by tissue pressure gradient. Reduced ovarian reserve reduces the rate of primordial follicle recruitment, so the ovary can function longer despite low ovarian reserve. And when it appears there are no oocytes at all remaining and the woman is menopausal in a completely depleted ovary, there may be a few oocytes that are trapped because as the ovarian reserve goes down, the rate of primordial resting follicle recruitment also goes down. So don't give up on women that you think have no eggs. This is just a picture of our IVF crew. Thank you very much.
Thank you, Professor Sherman. With this
Any
talk,
questions,
give us a lot of hope. Is there any question? Yes, Dr. Munir Filali.
Someone may have to help me with hearing on this.
So thank you for your presentation. My question is about the cyclophosphamide equivalent dose. Is it for you a relevant parameter, or do you use another parameter factor to assess the toxicity? Is about cyclophosphamide equivalent dose. The cyclophosphamide equivalent dose.
For toxicity of what?
Okay.
Toxicité des alkylants.
I really apologize for my hearing.
I'm talking about the cyclophosphamide equivalent dose. Is it a relevant factor to assess the gonadotoxicity of the chemotherapy, or do you use another factor parameter to assess the gonadotoxicity?
Well, okay, he's asking about gonadal toxicity. What we found with patients that have already had chemotherapy, but in our early days of ovary transplant, many have had chemotherapy, but only a short dose of it, which destroyed their developing follicles, but didn't destroy their primordial follicles. So in these cases, in fact, the first case that Mayru reported in 2005 was exactly a woman who had chemotherapy, but the ovary tissue was frozen despite all of her developing follicles being destroyed. And the primordial follicle survived, and in fact, she got pregnant with transplanting the ovary cortex back. So our conclusion from a lot of experience so far, we've had 32 babies, and there have been over 200 babies born from ovarian tissue transplantation so far in the world that have had chemo. And I think that it's pretty clear that the chemo is not hurting those primordial follicles. It's pretty clear that the babies are normal. We don't have any problems associated with prior chemotherapy toxicity. If that's the question, if I understood your question right.
Professor Hamama.
Sherman, do you remember Jonathan?
I apologize. These loudspeaker systems, I can't hear that well, sir.
You hear me now?
Yes, perfectly.
Great. Do you remember Jonathan Tilley, Tilley, from Massachusetts? The guy who demonstrating that even in monopostosis women, it is still very rare somatic cells which emerge in oocyte. Do you remember Jonathan Tilley?
Yes.
Yes. What do you think? You know where he is now?
No, I don't know now.
But you know the guy.
I know, I'm aware of what was done, but I don't know him. I don't know him personally. Yeah, I don't.
There's no any issue.
I don't know. I don't think there's any issue with that. The question, really, I guess, let me see if I understand. Can somatic cells in the ovary be converted?
By which we can imagine oocyte, even in women with pre-monoposis or monoposis.
No, what's happening, I think, is what I described. I don't think we're seeing somatic cells becoming germ cells, if that's what you mean. What we're seeing is that germ cells, primordial follicles, are trapped. It's like in the fetal ovary, it's the high tissue pressure when you have so few eggs left that eventually it's not just that the rate of primordial follicle recruitment is decreased because of low ovarian reserve, but the rate of primordial follicle recruitment is stopped completely. They are trapped oocytes, but they're just like the trapped oocytes in the fetus, they're capable of developing.
Yeah. The guy is already published in Nature Medicine, you know.
You mean like Tilly?
Tilly,
Yeah, okay.
absolutely. In Nature Medicine,
Yeah.
15 years ago, and to mention that by starting with very rare somatic cells, you know,
Yeah.
because when he injected, a fragment of ovary in mouse,
Yeah.
immunodependent.
I'm more. I didn't understand at first. It's Tilly's work. I have to tell you, and I just am very, very frank. I don't think anybody really feels that Tilly's work was correct. There isn't a scientist around now that really accepts what Tilly published, and he was dismissed from Harvard, and his data was either manufactured or just poorly understood in terms of counting cells. So he was suggesting there are ovarian stem cells, and I think nobody accepts anymore that there are ovarian stem cells.
Thank you so much. On va passer à la session d'après.